So it is my distinct privilege to introduce to you Dr. Kristen Ondeko-Ligda. She's an assistant professor of anesthesiology at the University of Pittsburgh Medical Center and the director of anesthesiology education at UPMC Mercy Hospital. She completed her Bachelor of Arts in biology and Spanish at Washington and Jefferson College, where she was a presidential scholar and a member of Phi Beta Kappa. She then graduated from Virginia Commonwealth University School of Medicine with her Doctorate of Medicine degree. She was a Jack Kent Cook graduate scholar and was elected to the Alpha Omega Alpha. She completed an internal medicine preliminary internship at VCU's SOM and anesthesiology residency and acute pain and regional anesthesiology fellowship at the University of Pittsburgh Medical Center. And she is also a dedicated hockey mum to 2 hockey daughters, a self-described okay-ish wife who doesn't cook but depends on her amazing husband to help her keep her house going. But on top of that, what she hasn't included is she was the creator and is the leader since 2014 of the Physician Anesthesia Mum Group on Facebook that has over 7,000 members and 4,000 consistently active members that are able to engage in very meaningful ways, and that is how I had the privilege of getting to know her. So without further ado, she's going to talk about crucial conversations, how to optimize regional and neuraxial use in the OR. And also, she's going to introduce kind of a really cool way that we're going to have the format for this lecture.
And thank you, Dr. Geller, for that amazing introduction. So we are going to talk about the utility of acute pain management for perioperative physician. We're also going to talk about regional anesthesia, neuraxial anesthesia for optimization of patient care. We're also going to explore options for how we can improve acute pain, regional anesthesia, analgesia for the operating room and for care of our patients, and also the post-operative time frame. I have no disclosures, but if anybody wants to give me any reason to have disclosures, I'll gladly take them. Again, I am that session between a bathroom break, between a coffee break. Feel free to get up as you go, but we'll be finishing on time. Also, feel free to tweet, Instagram, hashtag, LinkedIn, whatever. Also, I included the meeting hashtags up here, so please make sure to include the meeting hashtags. It's the AOCA Vapor 22 and AOCA 2022 if you're going to tweet any pictures for the meeting. So, I want to know who's here in my audience. Who here is private practice? University hospital, military, you can be both or more than one, outpatient center, trauma center, other, retired. I think there's at least one of, there's at least 1 or 2 of you in here. So who has an acute pain service at your hospital? Who wants to start an acute pain service at your hospital? You don't want that task. Who performs nerve blocks? How about catheters? How about uses ultrasound for your nerve blocks? Good. So this is that interactive portion of the afternoon. Let's get us going. Who uses ketamine in the OR? Okay, so when I gave this talk just a few years ago, there were actually very few hands going up, so I'm encouraged by this. But who runs ketamine infusions on the floor for your patients for post-op? It's like more hands keep going down. How about using lidocaine infusions either in the OR or on the floor? How about methadone for pain control, either perioperative in the OR? Okay, so we're going to talk about all of these things because if there was anybody who had their hand up the entire time, you probably can exit stage left or stage right to you because probably this is going to be everything we're talking about. So when Dr. Geller asked me to give this talk, we were talking about all these things about acute pain management, the OR, regional anesthesia, and whenever I was talking about these ideas, she's like, yes, all of it. I'm like, great, so let's incorporate this talk. But any talk on pain needs to start with a basic understanding of pain pathways. And then we'll talk about some other aspects. But here's the thing, when all of you guys are raising your hands of what you have available at your hospital, if I sat here and gave you this talk of what you should do and what you need to do, your hospital may not have those resources. Your hospital may not have the pharmacy on board, the nursing on board, may not have the inpatient support, may not have the availability of those medicines to even obtain them on formulary. So this is where we're coming up with these ideas of crucial conversations, because I want you to feel empowered, because empowered people empower patients. I want you to feel empowered to be able to think about how can we incorporate these ideas into our health system to improve patient care. So when we're moving forward, I want to think about this pain pathway. And this is the very basic understanding, because we think of the peripheral nociceptors. We have the trauma to the skin, either the incision, either the wound or injury. We have those peripheral nerves. And ideally, the local anesthetics can function right there, somewhere along that line of the peripheral nerve. As those nerves are entering into the dorsal root ganglia, local anesthetics can function in that dorsal horn, in the epidural space, in the spinal canal. We also can have opioids functioning there, alpha-2 agonists, and then we have our crossing of our spinal thalamic tracts, our ascending input, our descending input, and then we can have our opioids and alpha-2 agents working on the brain. And at any one of these places, we can modulate that effect of the patient's experience of acute pain. And so I know that several folks have talked before me. The amazing Eugene Viscusi, I think it was Dr. Jaffe had also talked. Think of those as lectures. Think of today as the review for the midterm, and think of your going back to the operating room as your final exam and how we can incorporate this. So today, when we're interactive and talking, I want you to bring in all of those concepts that you've learned over the course of this amazing week, and we're going to talk about these things. So this is in graphic form, what Dr. Viscusi had probably mentioned in his talk about opioids. So if we think of this circle as being the the entire world population, that little light pink pie up at the top is the amount of the United States population compared to the world. But when we look at this graph on the right, we look at the opioid consumption of the United States as that light pink area compared to the rest of the world. So we need to be able to bring in alternative methods to be able to improve that opioid consumption. So we think of that old way of thinking about this. The old way, opioids were that primary focus with very little need or use of regional anesthesia. But let's think about this as ultrasound, as techniques, as fascial plane blocks, as all of these things that you've learned and discussed become more prevalent and more popular in our medical practice. We've now flipped this paradigm. And we now have regional anesthesia, things like multimodal agents with acetaminophen and NSAIDs, lidocaine, magnesium, all these other agents with that little tippy top being the opioids now. Because our goal is not to rely on opioids. If anybody thinks opioids are the solution to pain, I want to think about the other talk on the opioid epidemic. And that's why we're here. So we need to be thinking and shifting that focus as to how we can improve our patient care. And so I just want to make sure everybody is aware that the ASA has guidelines for acute pain management in the perioperative setting. Many of these are long outdated. This has not been updated for several years, but it's always, if you're needing to fall asleep, if you need an extra reason to fall asleep to calm your brain down, I would highly recommend reading these guidelines when you have free time. So we're going to start with a case discussion. We have a 40-year-old male who's been clean from opioid abuse for 10 years, and he was walking the dog and fractured his ankle last week. If you were in Pittsburgh, where I'm from, I normally say slipped on the ice, but the only ice here in Phoenix is probably the ice in our drinks at the bar. So we're gonna say walking the dog when he stepped off the curb and fractured his ankle. He's coming to the OR today for ORF of the ankle and has concerns about opioids, relapse, and his pain. So what is your analgesia and anesthetic plan for this patient? Anesthetic, really just tell me a type. So, who wants to go first? Doctor?
Regional foundation.
But what would you like to do for your regional?
I would do a sciatic catheter and a simple triage catheter.
Okay. Is there somebody who would do something to the contrary? Okay. So you may or may not have ability to do the sciatic catheters at your institutions. I will say it's a time-intensive process. If you're somewhere that doesn't have an acute pain service, if you're somewhere that doesn't have somewhere to monitor or to be able to discharge your patients, personally, a sciatic catheter is what I would do 100% of the time. This guarantees that he can have 2-3 days of pain control. If he's staying inpatient, I would even extend that to a fourth or even a fifth day, if that is truly a goal for him of maintaining pain. If he's being discharged, then the ambulatory pump with a low rate for several days is a viable alternative. You can also do single injection, because I know not everywhere has that opportunity. So even just getting him that opportunity to block that pain sensation before it even starts, that's giving him some benefit. So a popliteal block, even a single injection sciatic nerve block, a popliteal block with a general anesthesia, a regional anesthesia straight are always viable options. But then we want to also think about that opioid sparing technique and getting on board early multimodal analgesia with acetaminophen. Preoperative acetaminophen can be given PO, 1,000 milligrams PO. Comparing the cost of PO versus IV, that's a whole different story, but I try to load all my patients with 1,000 milligrams of IV or of PO Tylenol before they even go back to the OR. And then even ketorolac, especially for somebody like him, that anti-inflammatory property, saving that ketorolac for the end of the case. So then 6 hours after he got that PO Tylenol, he could be due for that next dose. And then after that can resume ibuprofen, and having a solid multimodal regimen available in the background would be perfectly appropriate. And then I like ketamine. I love ketamine. At one point, there was probably more ketamine on the street corner when we talk about drug shortage availability than what I had in my hospital, so we reserved it for very specific populations. But ketamine is always a viable alternative, using either 20, 30, 40, 50 milligrams on induction, and depending upon whether they're staying inpatient or not, can also depend on whether you want to continue this as an infusion or even PO ketamine. I like PO ketamine for people who don't need to be in the hospital, like maybe they're going to stay overnight for monitoring. I'll do 20 milligrams of PO ketamine every 8 hours as a oral format for them versus an IV, but something to have as an adjunct for them. But I will say the biggest thing you're going to do for this patient, and this patient seems motivated, is having that conversation with the patient, with the surgeon, and say, throw out those misconceptions or preconceptions, what you may have. I don't care if you don't want to block for this patient. I don't care if you don't want Toradol for this patient, but this patient we need to be able to support him. Otherwise, he's going to have a chance at cycling back to a vicious cycle. And so when we move on to our next case, we're thinking about this same guy, except now the surgeon doesn't want a nerve block because there's a concern about compartment syndrome. So how do you handle this conversation? What are you going to discuss with the surgeon? Nope, not Dr. Geller. We're going to go with somebody in the back. Anybody in the back before how about I love people under general anesthesia? What would you do? I mean, those are still options. But then that other option is that we can still talk to the surgeon about the ideas of compartment syndrome. Does compartment syndrome ever really occur in that first hour, 2 hours, 3 hours after surgery? It's probably a rare situation for compartment syndrome to occur, if not almost impossible for compartment syndrome to occur that quickly after surgery. So for me, it would be worthwhile having that conversation with the surgeon. And remember, when we're talking about crucial conversations, for several of you in this room, you were fortunate never to have undergone the ABA board examination for taking the AOCA. For those of you who are not familiar with the American Board of Anesthesiology exam for the applied examination, there's actually an AOCA component. One of those AOCA components are communication with other professionals. These other professionals are situations exactly like this for communicating with a surgeon of what is best for this patient and being able to help support them. The thing with regional anesthesias, I don't necessarily feel like there's a right answer, nor is there a wrong answer, but it's what's best for you, what's best for your hospital system, what's best for your available resources, and what's best that you can communicate to all those people involved in your patient's care. So when we think about things like compartment syndrome, there's a lot of evidence out there. I don't think anybody's doing a randomized controlled study on this, but there's lots of case reports and information that talks about the compartment syndrome in this sense of compartment syndrome. True compartment syndrome is not masked by the nerve block. There may be a little bit of a delay, but sometimes that's more of the nursing perception that the patient has pain outside the block, not understanding or not appreciating what else could be going on. So does peripheral nerve block, does it affect perception in acute in compartment syndrome? And really, in the grand scheme of things, this study pretty much shows that there's no evidence in the literature that shows that peripheral nerve block truly blocks it. Because when we talk about the symptoms of compartment syndrome, it's that pain out of proportion to the injury. And it's particularly that pain with the passive stretch. So when I have my residents, when I have my fellows, when they're being called and I lecture them on day one of service, talking about the risks of compartment syndrome with regional anesthesia. Because again, our surgeons have this fear, our surgeons have this concern about compartment syndrome. But really, compartment syndrome should still be diagnosed with the best block on board, with a good block on board, because that passive stretching of the muscle should elicit pain. You can have that palpably tense compartment, which is often masked by the dressing. The pallor and pulselessness often are not even ones that we're concerned about, because that pallor and pulselessness are often late and they're not typically reliable in compartment syndrome. Paresis is often in that late phase anyway. But again, it's breakthrough pain. When you've had a patient who's been doing really well on a block and now this pain is out of proportion, it's previously well-functioning block and now this pain is out of proportion, that's where you start to get a concern for compartment syndrome. But rarely is this in that time frame of the duration of a single injection block. And if that's the case, I will say my experiences with compartment syndrome during the time frame that a single injection block is lasting are usually related to something like not having adequate hemostasis in the wound and having some aspect of an arterial injury, and not necessarily related to the fracture. And again, these were multiple studies and case reports, because really it's the case reports and studies that are out there in the literature that are talking about compartment syndrome versus actually having a true study that's prospective from the beginning. So you have this conversation with the surgeon. You're talking about doing a regional anesthetic technique for this patient. But how are you going to do this? You know, the surgeon's on board with it. He wants to support his patient. But he's like, doc, I'm still concerned about this nerve block. I'm still concerned about the risks of compartment syndrome. So is it a postoperative concern? That single injection to get ahead of the pain, so in that way you're allowing all these other adjuncts to be on board, to be able to get on top of the pain, so that patient, as that nerve block is wearing off, you should be able to get multimodal agents on board and support with other medications such as the Tylenol, the ibuprofen, or Toradol, the ketamine. But you can also have that option for a catheter if you're someone who does catheters. So that sciatic catheter that Dr. Geller had mentioned earlier, that's still a possibility. We typically run ours on a low-dose infusion. I have found that low-dose bupivacaine, 0.03%, pretty much supports a motor function. So that patient can still move their foot, do all their tests, but it's that sensory that's inhibited. And if that pain is breaking through on top of that, then that's where you would get concerned. Remember, it's that pain out of proportion, that pain with passive stretch. So if you're getting a call about that patient who has a concern for breakthrough pain, have that nurse put on that passive stretch, or try to move the toes or wiggle the toes if we're talking about that ankle injury, to see if it's causing increased pain or worsening pain. And again, at the end of the day, this is all a conversation of informed consent with our patients and documenting this. There are many patients who I have blocked on active anticoagulation because to them, the ability to be able to support their ejection fraction of 5 and 10% far outweighed their benefit than the small risk of having nerve injury. And so having that discussion with the patient, he is more concerned about being able to maintain and support his goals for staying clean, for not having a relapse. And this is important for the patient. So documenting that in discussion with the surgeon and the patient. Patient was educated on those symptoms of the pain out of proportion to the injury, the pain that is so much worse all of a sudden, or that pain with like that movement of the toes that is not that pain with passive stretch of those muscles. And so again, as I said, how would I do this? That sciatic nerve block, various approaches to it with a low dose if possible, with the adductor canal nerve block, and then either general anesthesia, or if you're doing that single injection, you can still do full regional anesthesia. So again, that opioid sparing technique, you still may need opioids, but in a patient, respecting the patient's wishes and the patient's autonomy, there have been many patients where I tell them up front, like, if you truly, and talk with a surgeon, if you truly want to avoid opioids, you have to tell me if you need something more and I won't give it. And I feel like that's really hard for us. Like, I have almost shifted my practice at this, mid-phase of our career, having a huge opioid epidemic in my patient population, to very rarely giving opioids in the OR for laparoscopic cases, because with good, solid multimodal agents on board, I may or may not need it. Do you have that hyperalgesic sensitization from our opioids? And so now I'm going to throw a wrench. Okay, we're still talking about this patient scenario, but we're going to toss a wrench into the picture. And the patient's now a 60-year-old woman with a history of myasthenia gravis who had fallen and broken her olecranon and now needs an ORIF. Okay? Her previous admission for a myasthenia exacerbation, she was intubated, she required plasmapheresis, they were almost getting ready to do a trach for her because she'd been intubated for days, and then following her extubation, she was on BiPAP for like 3, 4, 5 days, pretty much around the clock, until she was recovered enough to only use her BiPAP at night. She becomes sedated with opioids, and her saturations decrease. So what's your plan for this lady? So, in the front, Dr. Margolis.
Oh, Dr. Margolis, who does know results.
But again, we're thinking outside the box here. We're thinking.
I was thinking I was going to put a catheter in, but then I want to know, am I going to take out her diaphragm, but I would like to lower. So I want to offer regional. I'm a little worried about, myasthenia has other, in the left lung. Give me hints.
Lyme just with the laparoscopic fractures, sometimes there's neurological problems and stuff like that.
So what would you do? That's why we're here. We are all here. There isn't a right answer. Does anybody else want to offer up a different thought? Dr. Geller.
I would plan on a full surgical block for that olecranon area and try to avoid general anesthesia.
And where would you do that full surgical block?
So because I want to avoid taking out the odor coming with the thread into the diaphragm, I would either go infraclavicular or axillary, but with axillary I want to make sure I get the muscle cutaneous, so I may opt for the infraclav and to put in a catheter.
Did you sneak peek at my slides? But your surgeon wants to assess ulnar nerve function postoperatively. So now, how does this affect what you're going to dose this catheter with? So, does anybody have a thought of how they would do it? Dr. Geller.
I would use something dense but shorter acting, but have a catheter in place so he could assess the function and then I could redose it and still avoid general.
Yes, I love how regionalists think. So again, how I would do it is I would do that exactly as she mentioned. I would do the infraclavicular catheter. It's the best way to be able to support the respiratory status by avoiding the phrenic nerve at all chance. Not that you couldn't do it at the supraclavicular area, but you would still have that risk of spread. My goals are to put in that catheter to be able to minimize post-op pain. And you could still do, and the best regional anesthetic is the one you're most comfortable doing. So that doesn't mean that you can't do an axillary nerve block and go after those nerves. That actually, most people are familiar with that, have done some aspects of it. It's easy to do with ultrasound. You can see those nerves clearly versus the infraclavicular, which could be a little deeper. My goal with putting in the infraclavicular is being able to do a full-out surgical block there, but also being able to support with pain control for post-op to minimize those opioids to be able to allow that patient to be as awake and alert as possible. So I personally would bolus with 20 milliliters of 0.5% lidocaine. I would do a T2 intercostal brachii nerve block, because no use of doing the nerve block if you don't cover that tourniquet area or the area that they're prepping in the surgical field if that incision goes higher up. I think everybody forgets about the T2 intercostal brachii. So if I can make any mention to you as you're thinking about the nerve blocks you would plan, is do that. For those of you who are participating in any sort of Mocha Minute questions, I swear I had 5 questions on the T2 intercostal brachii. And it was okay guys, I get it. I'll make sure everybody remembers this nerve. But when I did this case, we bolus intermittently over the course of, every hour, every half hour or so with 5 cc's of 0.5% lidocaine. And then the last dose I gave before they started to close. So I had an initial 20 to get things going for the surgical block, We bolused a little bit here and there because this was a complicated elbow that had multiple pieces to it, and the patient knew there was a risk of going to sleep with general anesthesia. We pretty much let her pick her headphones, and she wore some AirPods and listened to music during the case, and we had to keep her at a little 30-degree angle because to be able to support her respiratory status at baseline because she was a little on the obese side. But what this allowed to do was in PACU, the surgeon was able to assess the function of that ulnar nerve, because again, we had that ulnar nerve right at the olecranon, was able to assess that hand function of the patient, was be able to assess, in particular that pinky movement, which we know is 100% ulnar function. So even with a bulky cast on board, we still could assess that nerve function. And then we restarted the infusion. That was bupivacaine 0.03 to be able to minimize opioids. And then we had a multimodal regimen on her. She didn't take an opioid medication the entire hospital stay. And we were able to support her, get her through the case, be able to support her respiratory status, and her family member was so thankful. But that also was that conversation with the surgeon. If I had gone to that surgeon and said, hey, I want to put a catheter in on this person, I want to do this, this, and this, they would have said no. But you having that information in your head, knowing what's best for the patient, knowing how you can reach the surgeon's goals and help the surgeon maintain the best environment for the patient, we're doing the best benefit for them. And so again, let's get back to a case discussion. We have a 40-year-old male who's been clean from opioid abuse for 7 years, and he was in a motorcycle crash overnight. He came emergently to the OR for an XLAP, and they did a splenectomy. Post-op coags and CBC are normal, and you're evaluating him in the PACU for pain before he goes up to the floor. So, how does this change your anesthesia plan for him now that he's post-op? He's in PACU, he's had an XLAP and a splenectomy. What would you plan for this patient? And I myself can think of like 3 or 4 different blocks, because I tell my fellows and residents and my colleagues who are jumping into the acute pain service world for the first time, if you don't have 4 options, you're probably not an anesthesiologist, because we're thinking about that plan A, B, C, and D. So again, the paravertebral, erector spinae, quadratus lumborum nerve block catheters, where you guys had these in some of your workshops, but TAP single injections can also be perfectly fine. The biggest thing with TAPs is that it's not as dense from the catheter side of things. You can still put in a catheter. It just doesn't cover more of that visceral aspect of things that a paravertebral or even some of that erector spinae can cover. In someone with normal coags, you can have them roll to their side. You can do that with ultrasound. The TAP single injections are great. There have been several patients where I actually brought them back 2-3 days in a row to do TAP single injections because their white blood cell count was too high for me to want to put in a catheter. But we did, just something to be able to cover their post-XLAP pain. And then you can have that PCA with dilaudid acetaminophen, ketorolac if needed, and plus or minus ketamine. But let's take that patient, and now we're going to, they had a liver lac, they had a massive transfusion protocol, because again, this is full circle. I didn't realize my folks before me were going to be talking about massive transfusion protocol. And if I had time, I would have edited the slide to talk about an LVAD patient too, but we're not there. So massive transfusion protocol. We have a post-op INR of 1.5, CBC with the platelets of 95. He was extubated this morning, and you're evaluating him in the ICU for post-op for severe pain. The patient does not want to risk relapse and wants to do anything to avoid opioids because that was a bad time in his life. So what are our thoughts for this patient of approaching them?
Less likely to do the epidural that was going to do the last slide.
Mm-hmm. Mm-hmm. Yeah, and I don't think, and again, this was from the guidelines for acute pain control aspects, and folks who are at home watching, I hope you're thinking in your head and talking out loud what these options are. But I would consider most of these peripheral blocks, the TAPs, the QL1, QL2, I would consider these to be low-risk blocks in the sense of what is a fascial plane block going to affect. Now, I would not be doing an epidural on somebody with elevated coags and INR. I would not be doing probably even a paravertebral, maybe depending upon the situation, but an erector spinae field block, fascial plane blocks in the quadratus lumborum or the TAPS plane are perfectly appropriate. Again, we have to have that informed consent discussion with the patient and talk to the surgeons, but this patient just had surgery, they probably still have drains in, there's risks of bleeding from multiple other areas that are of concern too. But if we want to support our patients' desires and wishes, we can have that conversation with them. The patients have the autonomous ability to say no. They have autonomy to say no. They also have autonomy to say, I want my pain under better control. What can you do for me? And so I often lump these, and these are also, I threw on this slide because this is also talking about all the different anticoagulation categories. And so, this is that person who's at Eliquis, this is that person that's been on Pradaxa or on Plavix. And again, I'm okay in many of these people doing low risk blocks in that informed consent discussion. The other aspect about the erector spinae or the quadratus lumborum is oftentimes they're also functioning as their own compression. So they're laying in the bed on their back and they're forming a functional compression against it. When we do blocks for rib fractures, I pretty much will offer an erector spinae to just about anybody, regardless of their anticoagulation status or their coag status, because they're functioning as their own compression on it. That risk of having pulmonary decompensation in talking with the patients can far exceed the risk of having any sort of bleeding and in having that discussion with the patient. But the best nerve block is the one you feel most comfortable doing, which is why the training on the ultrasound, the training in the workshops of being able to build our armamentarium of all these different options will help enhance our patient care. So what changes in your anesthesia plan? Probably not a paravertebral without an epidural. I can't tell you the last time I've done epidural, so epidurals aren't necessarily in my repertoire of what I go to instantly when I think of rib fractures or XLAPs or those sort of patients, because it's a deeper block, so there's just more bleeding, deeper structures to get to. But it's that informed consent discussion with the patient and thinking about alternatives such as erector spinae, quadratus lumborum, putting in catheters plus or minus. If you're not infected, really the one group of people who I hesitate on putting catheters in are those who have positive blood cultures, elevated white blood cell counts. Those are the folks who I will shy away. I would rather bring them back every day for single injections than to put in a catheter when they're still febrile with elevated white blood cell count with bacteremia. And so again, that multimodal analgesia, because of the liver lack, I'm going to decrease my acetaminophen dose to 650 milligrams or even avoid it, plus or minus ketamine. And then if I'm not doing a block for whatever reason, say the patient says no, then I will offer oftentimes the IV lidocaine infusion. And I feel like the IV lidocaine infusions are kind of in vogue, out of vogue, depending upon where the literature is reviewing. But when we look at the pain pathways, we see that essentially we're triggering these pain receptors in our periphery. And it's going into the central, contributing to things like neuropathic pain or this constant acute pain triggering of our spinal signals up and down our ascending and descending pathways. So when we can use IV lidocaine for patients, what we can do is kind of block that sensitization of the spinal thalamic tracts from the infusion. If we can't direct it locally to those nerves that are triggering the nociceptors, then we can do it in a systemic effect. So in a patient who I can't offer a block for various reasons, or in a patient who's refusing a block, I will often add IV lidocaine. So, and some of these studies are older, from 2004, some are from 2016 or 17, but really you can decrease the amount of central hyperalgesia and pretty much decreasing the sensitization of those nociceptors with the use of IV lidocaine. And so there were different studies, this one in particular by Coppert in 2004. This was using IV lidocaine during the time of surgery, pretty much up through the time frame after, within 1 hour after the end of surgery. So not a huge post-op infusion. In the next slide, I'll talk about some of the ones who are using the post-op infusions. So this Coppert study showed less pain during movement, less morphine during the first 72 hours after surgery. And pain, as we've discovered, that pain is very much a supratentorial effect of those cumulative signals of nociceptive pain that are hitting the brain. So if we can do something to be able to block those pain signals from reaching the brain, then maybe we can do something to affect that analgesic effect for post-op or block the development of chronic pain. And so when we think about lidocaine infusions, alternatives to regional anesthesia, laparoscopic surgery, someone who you can't do an epidural on, or a deeper block, part of enhanced recovery protocols, a trauma. Like, I have taken care of some of the worst trauma patients, and in particular, the most sensitive, I think, to the pain are burn patients. I had a gentleman who was 85% total body surface area burns from welding at 2 in the morning, or at least that's the story he was telling us. But he was in the hospital for 90 days, in the ICU for 90 days, dealing with constant dressing changes and excisions and grafts, and that pain was probably some of the worst we had ever had for him. So we tried to do lidocaine infusions for him after surgery. We had ketamine on board for him. We had all these other multimodal adjuncts, in addition to methadone and other meds, to be able to help try to support him for his pain through surgery. I just want to mention the Ottawa protocol from the 2016 IPE paper on a bolus of lidocaine, continuing on with an infusion. I typically will start everybody at 0.5 milligrams per kilogram per hour, and then you can bump up as you need to, but with most folks, they're pretty stable on that 0.5 milligrams per kilogram per hour. You can increase or decrease the dose, and then I will continue it typically for at least 24, sometimes 48 hours. Sometimes it's when bowel function returns. So when the patients are starting to pass flatus after an XLAP, or when we have that first stabilization of surgeries, like in this polytrauma patient, when they're stable to go to the OR, I'll usually leave it running for another day or so. But it's up to us as the acute pain team as to when we feel like we need to be able to turn that off. So typically, though, 24 hours is the initial recommendation, and then extend it based on what your goals are for the patient. And so the last patient that I have for our discussion, we have a patient with it, and I added this last night thanks to some of the discussion with folks at dinner, a history of opioid use disorder on Suboxone. Think of this as your midterm, studying up on all those previous speakers and what they've discussed. Shortness of breath, fever, chills, and found to have an empyema. She's coming to the OR for a VATS. What's your analgesic plan? Is there any more info you'd like to know? Normal. Do you want to do a block? Yeah, so you want to do, a block for her, single shots if you're concerned about elevated white blood cell counts. If the patient truly has fever and chills, that single shot injection when they're doing surgery probably isn't going to change much. Would I do a single shot epidural? Maybe not. Would I do a paravertebral? Maybe not. But I would probably try to at least offer her an erector spinae block, especially with them doing surgery and the decortication. So that can always be an option to have in your back pocket. And then again, the multimodal medication, but just like I would continue that Suboxone, because Suboxone, even on the highest doses, still have up to, if not more than 12% opioid receptor availability. And the risk of relapse, the risk of trying to get them to a point without opioids, of restarting Suboxone, may not necessarily be something that is easy to do. So, maintaining Suboxone through the perioperative period is the current vogue thing that is in the literature for what we need to do to support the patients. Whereas I feel like 5 years ago, the goal was to stop Suboxone to get them through surgery. And then now we have the same patient for Suboxone with an elective total knee arthroplasty. And then, if we're here, this is the best option to be able to support the patient, is to do the adductor canal block. Talk to the surgeon about the adductor canal, about sciatic block. Can we put in a catheter for the adductor canal? Can we do something more to be able to support her pain through the perioperative time frame while still maintaining the Suboxone? And then continuing, if there's no blocks on board, lidocaine with if your lidocaine infusion, otherwise ketamine and your multimodal agents to be able to support them. So I do want to touch base really quickly in the last few slides on some of the multimodal agents. The NSAIDs, ketorolac, ibuprofen, we want to avoid them in our high-risk patients, those patients over 60, peptic ulcer disease, steroid, alcohol, or multiple NSAID use, that first 3 months of ibuprofen use, concomitant use of anticoagulants. So again, NSAIDs may not necessarily be the end-all be-all for everybody. That ability to use acetaminophen, I personally think the PO works just as fine as IV. So as soon as I can, I will start the patients on PO acetaminophen. That IV formulation does have greater bioavailability, but the literature doesn't really say if it's actually affecting outcomes. Magnesium, that's a possibility, although not one that I use directly in my armamentarium. I'll talk a little bit about ketamine. We have IV lidocaine, which I mentioned in the slides before as options, gabapentinoids, there's not really, unless it's a neuropathic pain, there's not really an indication for routine use based on the literature. That ability to use dexmedetomidine, dexamethasone for PONV and PRN. I do want to make mention about ketamine, although I feel like more people are familiar with ketamine than what they had been in the past. But the biggest thing about ketamine is it does have that intramuscular option. So IV, IM can also be options, in particular for just reminder of using it in that in multiple modalities. It is hepatically metabolized, and it does have an active metabolite in norketamine. Children tend to have more rapid absorption, so their rates of norketamine tend to be higher in the body for those metabolites, and they do cross the blood-brain barrier. It has a first pass effect with the liver, so you must give a higher dose in the oral or even the rectal format for ketamine. So in oral doses, I tend to give a little bit more than what I would have if it was that IV infusion. It is that NMDA receptor antagonism. It interacts with opioid, cholinergic, monoamine, purinergic receptor systems. And I actually like ketamine, and I always keep this in the back of my head for those severe bronchospasms that are in the operating room. So it's great for bronchodilation, and when you have that awful bronchospasm, give the ketamine at the beginning of the case. I will say I've never had a bronchospasm on somebody I'm giving ketamine preemptively to at the beginning of the case as part of my induction plan, so I'm sure that the bronchodilation effects are factoring in. It also increases salivation, so you may want to consider the anti-sialagogues with it. It does have the dissociative state, and that's what I always warn patients about when I'm starting ketamine infusions. The biggest thing for them is that I tell them that if they start to have any of the other effects, such as hallucinations or concerns with hallucinations, if it doesn't bother the patient, it doesn't bother me. So this is often a conversation that I'm having with the patients, with the surgeons, with their family members, because the patients are like, dude, this is cool. I'm like totally tripping. This is great. And the family members are like, oh my God, he saw green fairies floating in the corner, and they're the ones freaked out. So having that conversation extends beyond the surgeon. It extends beyond the patient. It's talking with the family members to make sure they know that if their family member is comfortable or their loved one's comfortable, we're okay continuing it. And so in this perioperative pain world, I typically am giving like anywhere from 5 to 10 milligrams per hour as a continuous infusion. In the operating room, I'm typically starting with a bolus, and then we're continuing the ketamine as an infusion if the ketamine infusion is part of our plan. And so it's a great multimodal therapy that I use in my routine armamentarium. Obviously, that concern for nystagmus, we talked about the disorientation from that dissociative state, increase in intracranial pressure, so I tend not to use it in the head injury patients. I've never had a patient have apnea related to the ketamine, but that is, in the much higher doses, a possibility. So I also want to mention real quick about methadone, because I feel like methadone is this medicine that's in vogue and vague that, we tend not to use it in the OR, but it's still great for our patients. So it had been used in the 70s as an anesthetic agent. It's bound to alpha-1 glycoprotein, it has high oral bioavailability, it has that multiple uses for effect, it has an NMDA receptor effect, it has biphasic elimination. So when we have our patients coming in on methadone who are coming in for their daily methadone treatment, that's not a good medicine to use for pain, because once that first 8 hours of the alpha phase elimination is done with methadone, it's not in their system anymore functioning in a pain format. So that beta effect, that 30 to 60 hours of methadone use, that's what keeps the opioid withdrawal cravings at bay. But if we're truly using it for pain modalities, we need to be giving it more frequently, or at least we need to be able to give it higher as an upfront dose. And so this was a study from Karish back in 2011 that showed that optimal dosing. So that 20 milligrams of methadone at the beginning of the case. That 20 milligrams of methadone at the beginning of the case had a nice analgesic time frame that decreased the amount of opioids required for that first 24 hours or so after surgery. So in my complicated spine patients, my polytrauma patients, my burn patients, I try to load that methadone up front, and I will maintain methadone 5 milligrams every 6 hours, or depending upon what we need to be able to help support the patients through that perioperative time frame. And so, I think one of the reasons why methadone is not as in vogue is some of that stigma associated with it, but there's also that trend towards shorter half-life. People will freak out more, especially the nurses on the floor, when they have that methadone. Oh my God, it lasts forever. Well, yes, but really the respiratory effects of methadone occur in that first 8 to 10 minutes after methadone is being administered. So in the OR, they're already intubated under general anesthesia by the time that respiratory effect is continuing. Later on, when it's on the floor, you shouldn't have the respiratory depression occurring later on, but it's still something where we would hold doses if the patients are sedate or having effects from the methadone. And then, again, I do want to make a quick mention in the last couple of minutes here about the idea of intrathecal morphine. And who uses intrathecal morphine as part of your ERAS protocols? Yeah, I mean, we typically yes and no using it. I feel like the literature is mixed, and there's ones that were saying, hey, intrathecal morphine for prostatectomy, go for it. There was another one that was talking about intrathecal morphine for colon resection. And this was one, in this study, they were actually giving local anesthetic with it, and the patients were having improved pain scores, decreased length of stay. There's also the controlled study that was after liver resection. So I literally have multiple studies here, but I don't necessarily feel like the hospitals with enhanced recovery protocols, we have certain surgeries where we are using the intrathecal morphine for in our enhanced recovery protocols, but that's not part of our routine use in this current day and age right now. So yes, and be able to finish up here on time, and my last slide, both of these are my hockey kiddos, and when I'm not doing my anesthesia thing, I love being the hockey mom, and I'm the team photographer for everybody. So those are pictures that I actually took. So what questions can I have? I know we covered a lot. Yeah, mentally in my head, I was looking at the clock, and I was like, oh crap, like we're going to 1:15, but we're ahead of schedule.
Yes, we are. Thank you so much, Dr. Ondeko-Ligda. I invite you to sit here. We're going to have a microphone brought up. And anyone who has any questions, we're going to begin the Q&A session. I have a million, and I'm going to try not to hog the attention of our esteemed keynote. So please come up to the microphone. But we're in an intimate environment. I think if you need to call out a question after putting up your hand, that will work too.
Yeah, if you don't think you have a big enough mouth, by all means, come up to the microphone. Otherwise, feel free to talk at your seat.
Dr. Henson.
Dr. Geller terrifies me, so I'm going to do what she asks. No, you described a case of a splenectomy, a trauma splenectomy, a 20-centimeter incision, 10 dermatomes, and yet the choices didn't include epidural. And I'm just curious why. Why wouldn't that be the absolute go-to for that patient?
Because at our hospital, anticoagulation is super important for the trauma surgeons, so they would want to be starting early, like early enoxaparin use and other things, and we just have our stop protocols on Lovenox with an epidural in place. And for us, some of it's like that risk-benefit analysis. Like if I do something different for one patient, like the epidural, where I will do epidurals for multiple bilateral rib fractures where I need to cover much higher levels. But for an XLAP, my goal is mobilization too. My goal is to get them up, get them moving, get them walking. And I want to be able to support that without having any risk of weakness.
So you're not walking thoracic epidurals for laparotomy? Well, I guess if you're not doing
I wouldn't be doing a thoracic epidural for that high laparotomy.
Okay.
Yeah, that's just at University of Pittsburgh. I will say I can probably count on, double digits the number of epidurals that I have done for those patients, because our paravertebral, our rector spinase, my goal isn't to get you to zero pain, but my goal is to get you to be able to support everything. And I feel as though we often have the anticoagulation that's like missed, or that risk. Like, do I want to have that as one extra thing?
So that's a very nice segue into one of the questions that I had. So I'm predominantly peds, but we take care of all the way up till, early 20s. And we have colorectal surgeons that have avoided us using epidural analgesia for the reason of not wanting to have a catheter and wanting them to get up and walking around. And we came up with a strategy to use low dose local, have it to be a very low thoracic epidural, and they were still able to get up with assistance 3 times a day and avoid maintaining a Foley catheter. Have you had any opportunity to employ those types of strategies where you're at?
Yes, typically not for the abdominal surgeries, just because for me, my experiences, I can get that patient just as comfortable with alternative modalities, but I typically reserve my epidural use for the rib fractures and for those polychest trauma patients.
So that's another question I have. Let's say you have rib fracture, it's unilateral. Would you ever employ an erector spinae catheter for rib fractures, and would it be one of your kind of go-to choices?
Oh, 100%. Either the paravertebral or the erector spinae. And I will say, some of it depends upon the patient's body habitus. So when I have somebody who I don't see that clear pleura, or I don't have clear visualizations, I may be less inclined to do the paravertebral approach as I would be for the ESP, because I see the transverse process on everybody, because that's a very distinct picture on the ultrasound. So an ESP to me would be a first-line go-to on somebody if I am not seeing distinct pictures of their anatomy.
And in the osteopathic realm, we're really good about palpating transverse processes, correct? So I get asked the same question too. I have a patient, they have a chest tube, or they're going to get a chest tube. Which block would you potentially use for a chest tube? And I tend to lean towards erector spinae for the same reason. Usually when you have one, there may end up down the road being an anticoagulation facet. Do you use them for chest tubes?
Yes, chest tubes for rib fractures, chest tubes for post-op VATS. Yes, erector spinae, paravertebral. And I will say, as somebody who works with lots of trainees all year long, I also have to take into picture the person, the operator. I don't necessarily want my intern, who's on the first week of the rotation, doing a paravertebral on a patient. Now, with a chest tube, we've already covered the pneumothorax. So from my side of things, it's like, so what if you're a little bit into the pleural space? We've already got that chest tube on board, but I don't really want to voluntarily do it. But for somebody who is novice to the anatomy, that also can be some colleagues or in teaching at workshops where folks are here learning those techniques. I feel like the erector spinae is a great gateway block for those who want to build in like truncal blocks into your armamentarium. So that erector spinae, you see bone, you're protected by bone. You know, even if you may not see your needle 100% perfect, you should be able to get that bone aspect and see that tissue deflection well enough to know where you are, versus trying to figure out where you are when you're dealing with pleura and lung tissue below. So for those of you who aren't as comfortable in doing truncal blocks, I feel like the ESP is that gateway block. Are you going to get them Are you going to get them to the same level of comfort as you will with an epidural? Probably not. But the safety profile, if they accidentally get, or there's concerns for a PE, they get started on a heparin infusion, they get Lovenox, they get something. The safety profile with an ESP block is just, to me, far greater than the risks I would be willing to entertain with an epidural.
So I was able to convince a pediatric surgeon who was, let's say, regional averse. He didn't want to commit the 10 minutes of time or cost, if you will, that to utilizing these very great modalities. So one day he comes up from another hospital, and we happen to have some sterile ropivacaine remaining after doing a caudal shot for a urological surgery, and he said, would one of you be able to do an erector spinae block or some kind of block for me? I fell on a fence, I broke 3 ribs, I'm operating all day. And I'm like, oh, this is sketch. So, well, we have some stuff. I'm not going to pull anything out and utilize it inappropriately. But he begged us, and we did an erector spinae block. And he said, holy shnikes, this worked nice. And then he's standing there operating all day. And he said it went from that side, because it was unilateral, it went from that side. He felt it migrate down the plane, and he had a numb butt after a while. And he said, and I got a good 12 hours out of that, and by golly, he let us use erector spinae blocks in the future.
And I think that's also where, for me, using erector spinae blocks or quadratus lumborum or paravertebrals, I see that value when I do these on the post-op patients, when I do them after the XLAP is done overnight for the trauma, because I'm not going to take 5 minutes when the trauma's coming up to the OR to do a block. Clearly that doesn't happen. So when I see these patients post-op and they go from laying in bed stiff as a board, not wanting to move, to now sitting in the chair within that hour, the nurse has them out of bed, the nurse has them up and walking, to me that shows that I see the physical, in real time, live evidence that the blocks are working. And it's not that I don't like epidurals, it's just that I deal with a very high risk patient population where, the risk for infection, the risk for anticoagulation, the risks for comfort,
and
inadvertent,
atelectasis, right?
Yes, and inadvertent injections, all these sort of things. Like I see the results and the benefit from using the paravertebrals, the erector spinae, and so for me, that's something that I will do 1,000 times over. The person who's coming in with rib fractures on Eliquis, on Pradaxa, on Plavix, on any of these high-risk medications, when I see them statting on 92%, on 6 liters high flow nasal cannula, or 10 liters or 12 liters, they're at that risk of intubation. Doing something is better than nothing, and doing it today is better than waiting till tomorrow when they've been intubated overnight. And I think back to 10 years ago when I was first starting out as an acute regionalist, before the INR cutoff was 1.5, like no anticoagulation. We had to follow these strict rules. And I would come in the next, wait a day after trying multimodals, and the patient would be intubated or failed their respiratory, waiting for that anticoagulation to wear off. So having something such as the erector spinae and your armamentarium are still something that you can do to be able to benefit your patient now, today, after that informed consent discussion with them. Because I would say it's the rare patient who's going to say no when you talk to them about that risk of bleeding and explain to them they're going to be laying against your back. You have broken ribs that if you're going to bleed into your chest, they're probably going to be triggered from the ribs than anything else. You already have a chest tube in. And when you talk to them about the whole situation, getting them to be able to support their breathing today, it's the rare person that I have encountered that would ever say no. And I actually don't know if I've had somebody say no who, I always give them the option, but when they're truly respiratorily compromised, saying yes is what often comes first for them.
Awesome. Dr. Griffin.
Just a quick question. Great lecture. On a patient you want to really avoid opioids with, can you just comment on the intraoperative, what meds you would use intraoperatively, dexmedetomidine or any others? What's your regimen for general anesthesia in addition to the multimodal?
So in addition to multimodal, ketamine, typically if I'm loading with ketamine at the beginning of the case, anywhere from 20 to 50 milligrams, I'll maintain 10 milligrams per hour as boluses throughout the case. And then depending upon, and I will say, it's not that I would never use the opioids, but if it gets to that point where, I've deepened their anesthetic, I've given extra doses of ketamine, I've made sure that we have Toradol, we have acetaminophen, we have all these meds on board, I have given the Dilaudid. It's not that I want to, or I've given an opioid to be able to support that particular case. But I will say for most people, depending upon the type of case, you can oftentimes get through. And again, plus or minus the regional block. If they have the regional block on board, they probably don't need much of anything beyond that.
I have a couple final questions, but anyone that wants to ask a question, you can interject. One of the strategies I'd heard as an option for a trauma patient where I won't know till I'm through surgery whether or not there would be a possibility for compartment syndrome. That's a big discussion, and you really covered that nicely today. Have you ever placed a catheter with saline and then waited a prescribed amount of time, then bolused it and started an infusion?
Oh yes, we actually have one of our surgeons who that was our standard protocol for him. Otherwise, some of my colleagues would stay and do the post-op block. But when you're in surgery for 5 or 6 hours, doing a block at 8 o'clock at night and coming back after I've been home for 3 hours isn't something I want to do. So I will place that block with saline in the perioperative time frame, like pre-op, saline, sciatic catheter, and then dose it postoperatively. Or when they get to PACU and the surgeon has signed off, the surgeon has checked nerve function, everything has been deemed appropriate, then I bolus from the pump, like I'll put in a 20 cc bolus of the dilute bupivacaine or ropivacaine from the pump, and then continue the infusion, or just do PACU boluses in the PACU and then continue the infusion. And if we're still there, because our acute pain team, when I'm on acute pain service, I'm usually not there late at night, but sometimes our colleagues will also go and grab the ropivacaine 0.2% and bolus in the PACU once they got the clear after the nerve assessment has been done, and then we can continue the infusion. But yeah, that's a great point. 100% I've placed the saline catheters.
I've had some surgeons when, as you know, orthopedic surgery versus vascular surgery, doing an amputation above or below the knee. Sometimes we've been asked not to apply a local anaesthetic because they will need to try to know how far up they need to go depending on their reason for the amputation, and they need to look at muscle and nerve function during the surgery, and so they've been okay with engaging with it being a saline driven until they've been able to figure out just how far up they need to go. So I found that interesting because they're still amenable, but they want to wait for those reasons.
Yeah, I would actually say for many of my amputation patients, in particular the ones coming for vascular reasons, if they have vascular reasons to have an amputation, they probably have vascular effect on their heart too. So I've done many of them, AKAs and BKs, under straight local. You know, especially now in the age of music in the OR, I pretty much say, here's some headphones, pick the station you want to have, but you're going to have a little HH hand-holding anesthesia for you today. So we're going to get that sciatic and femoral, like whether you do an adductor canal or femoral can be dependent upon the type, but that's your anesthetic. And again, you talk to the patients, say you're not going to feel anything. If you do, tell us. But with a great block on board, in particular the vascular patients who their cardiac function may also be just as vascularly compromised, this is a great option to have.
I like the music facet because the only thing beyond, you know, the fact that you have it completely numb is that they don't want to be disturbed by the sounds of surgery, and so you're blocking that too. So the one final question as we're ending at time, there has been a little bit of movement in the why don't we adopt adding buprenorphine as an option in surgery, knowing it is part of Suboxone, but not in that realm, but as a naive patient, sometimes you use methadone, maybe buprenorphine is an option for certain types of procedures. Have you heard any movement there on your side?
Yeah, and I haven't. To me, I think some of it is that buprenorphine in, you know, that prescriber training, and it was actually Dr. Viscusi's talk that I heard in June, which I think was the same one he gave here, where it actually it forced me to go out and get my buprenorphine prescriber training. It was 8 hours. A couple of my colleagues who work on the weekends at Suboxone clinics, they, you know, told me yes, 100%. They walked me through, so it was an easy way to get that buprenorphine certification. But I feel like from the hospital side of it, that buprenorphine still has that limited ability to prescribe. Like for us, it's not readily accessible unless the patient already came in on buprenorphine or unless you've gone through the prescriber training. So I couldn't prescribe it or give it perioperatively if I wanted to.
That's too bad. We have it in our neonatal arena because they found that buprenorphine was superior to methadone for neonatal abstinence syndrome, and they were then needing to have opioid therapy to bridge them over from birth onwards for a much shorter period of time with better outcomes. So I think it'll be an interesting avenue in the future, but with those hoops to jump through with all the extra training.
Yeah, whereas methadone is great, and I use it for a lot of patients. I love it for the complicated back surgeries. I feel like it just helps smooth their post-operative course to allow the PRN opioids to actually kick on board, to allow the multimodal agents to kick on board. So all of our multi-level fusions typically are having methadone in that preemptive initial induction, because based on that one slide, methadone is most effective at that before incision, beginning of the case versus giving it at the end of the case. Because the whole idea is to use that the multimodal effects of methadone, that NMDA receptor effect that has that small, that the blockage of cholinergic uptake, all those sort of medicine, all those sort of other effects of methadone are great at the beginning of the case to prevent that or block that nociceptive sensitization.
And then you don't need to worry about a basal infusion if you were to employ a PCA even briefly in the post-operative period, right?
And actually most of our polytrauma or back patients are on, like I will actually use PRN as my methadone for whenever they're on my pain service. So I'll have 2.5 and 5 of methadone as PRN meds for them instead of an oxycodone or an oral.
Interesting. I would like everybody to give a round of applause to our keynote, Dr. Ondeko Ligda. Thank you so much.